Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Good morning, everybody. A heart welcome from my side. My name is Wolfgang Jani from the University of Ulm in southern Germany. And also on behalf of Medscape Oncology Global and on behalf of this esteemed faculty, I would like to welcome you to this symposium at the very start of the ESMO 2025 convention. In this symposium, charting the course for metastatic breast cancer care, optimizing first-line treatment and beyond. I'm a happy man because I have you and also a very esteemed faculty this morning. The faculty which came basically from all over the world. I would like to welcome Professor Rebecca Dent, who came all the way from Singapore. Professor Nicholas Turner, who came in from London, and Professor Peter Schmidt. Professor Dent and Professor Turner will give us a lecture very quickly, and Professor Peter Schmidt will help us with the discussion afterwards to digest and discuss what we heard from Professor Dent and Professor Turner earlier. And that will be, of course, in the context of ESMO 2025, where we expect new data, practice-changing data, I expect, beyond the paradigm shifts we saw recently anyway. Some examples here: biomarker-guided treatment optimization, of course, ADCs, ADC sequencing, CNS and HER2-positive breast cancer, and many other topics in all tumor biologies, from triple-negative to hormone receptor-positive, HER2-positive. So we'll have the new data here, 2025 ESMO. And of course, at the beginning of this meeting, we'll have a wonderful chance to see what is state of the art right now, what is already changing after ASCO 2025, what might change after ESMO 2025. And with this, I'm very much looking forward to the first lecture, which is done by Rebecca Dent. Rebecca Dent will talk about shaping the future in HER2-positive breast cancer, advances in HER2 targeting strategies.
Thank you very much for that kind introduction. It's wonderful to see you all here on the first morning of the ESMO 2025 in Berlin. I think all of us on stage are old enough to remember when someone was diagnosed with HER2-positive breast cancer, we had a little bit of a sigh like, oh no, this patient's not going to do well. But now when my patients come to see me and they have HER2-positive breast cancer, I say, I've got lots of options. I just have to strategize which one. So it's an exciting time for patients, for us, to be able to offer them therapy that provides long, durable benefits and potentially cures, even in the metastatic setting. So where are we now? I'm going to talk to you about some of the current standards of care, and then where are we heading? Some of the recent data, some of the ongoing studies, and where the future is headed. So it's important to sort of go back to the guidelines to give us some perspective of where we're at. And I think it's really reassuring to see that the guidelines are expanding and expanding as time goes on. So I think we've realized that when we look at HER2-positive breast cancer, we have ER-positive HER2-positive, and we have ER-negative HER2-positive breast cancer. And that immediately creates a little bit of a divide, such that if patients are hormone positive, we have the option of giving an induction therapy and then putting them on endocrine therapy and potentially giving them now a CDK inhibitor. And if they have HR-negative HER2-positive disease, traditionally we've given a taxane plus HP followed by antibody maintenance. Now, what I find amazing is having come to ESMO for probably 20 or 25 years, I find that the guidelines used to be very different. But I find now the guidelines more and more are actually mirroring what we do. And so it's gratifying to see that both the ESMO guidelines, NCCN, and ASCO all look very similar when we're talking about HER2 positive breast cancer. So it's impossible not to credit where we've been and where we're going. So I think many of us remember the day when the Cleopatra data was presented, looking at targeting with dual targeting HER2 blockade, where it was amazing to see an improvement almost 20 months in terms of PFS, but more importantly, a 60-month median overall survival. And I think we all have these patients in our clinic that after induction therapy continue for years on dual blockade. And here we can see the median OS, almost 5 years with first-line therapy. And then for many years, we talked about the Amelia trial. So once patients had progressed on first-line therapy, then what do we do second-line therapy? And why I think this is so important is it marks a pivotal shift. And this is first-line ADC development, where we looked at the development of TDM1. And this was the first time, again, in this second-line setting, that we were able to show both PFS and overall survival benefit. And I remember this is like this yesterday. We had well over 20 or 30 patients on this study. And it was really amazing to see, after having been on first line so long, to be able to garner benefit in this second line setting. But then, as we know, a tsunami of development came, realizing that this antibody drug conjugate development could actually help us treat breast cancer patients by delivering more potent chemotherapies that we normally couldn't because we weren't able to deliver them more focused to the tumor. And so you can see with TDXD, we have a better drugs to antibody ratio. We have a tumor selective cleavable linker. And we also have this concept of bystander effect, which the first generation of ADCs just didn't have. And so we had the Destiny Breast 03 study looking at second or third line. So again, more heavily pre-treated patients. We had more than 50% of these patients were treated in second line, 50% of those patients treated third line, 60% had prior pertuzumab, and more than half were Asian patients. Primary endpoint was PFS by BICR, and these patients were randomized to our traditional TDM1 or TDXD. And I think many of us still found it hard to believe that we saw primary endpoint 30 months versus 7 months looking at TDXD with a hazard ratio of 0.33. And across all different subgroups, we seem to see this benefit of TDXD versus TDM1. And then when we looked at key overall survival, again, initial presentations showed that we didn't reach this. These patients were living a really long time. And I think one of the things that really struck me was that the median PFS in TDXD was greater than the median PFS with first-line therapy of THP and Cleopatra. I think never before had we seen a PFS in the second line longer than what we had seen in the first-line therapy. And again, the NCCN guidelines very quickly incorporated TDXD as a second-line option for our patients. Similarly, the ESMO guidelines also incorporated it. But I think, as many of you know, around this time, we also finally were seeing that we know that patients with HER2 positive metastatic disease, more than half of them develop CNS metastases. So now we have compounds that actually are active in the CNS. And so we see this mirrored in the guidelines that we have for patients, where we see this early stratification to allow for the use of TDXD early in the treatment of patients with metastatic disease. But we also saw the data from the HER2 CLIMB study, the phase 3 trial. And it's really interesting to talk to radiologists because they'll say, "What are you using?" We finally see something where we're seeing those responses in brain. And this was in heavily pre-treated patients that are HER2 positive, greater than equal to third line. And all of them had had prior trastuzumab, pertuzumab, TDM1 with a prior endpoint of PFS. And these patients were randomized to capecitabine trastuzumab versus the triplet of trastuzumab, tucatinib, and capecitabine. And again, we're seeing improvements in PFS and overall survival. Again, this is heavily pretreated patients, 3 or more greater lines, almost 2 years overall survival, and some activity in the CNS. And we can see that in terms of the toxicity profile, and remember, these are compounds that we can give without intravenous administration, but we see grade 3 diarrhea, PPE, and increases in ALT. I think the most notable and what makes the most difference for those of us in clinic is that we finally had compounds that were active in the CNS, especially in active brain metastases. So almost 200 patients in this study, and we see an almost 50% response, intracranial response versus 20% with the addition of this TKI. As well, we see data from the phase 3b4 Destiny Breast 12 study. And this was looking at TDXD in HER2 positive advanced breast cancer with or without brain metastases. And again, these are patients have received less than 2 prior lines of therapy in the metastatic setting. They could not have had LMD, but we have seen subsequent responses in the leptomeningeal disease. But we had two groups, one no baseline brain metastases and one baseline brain metastases. And you can see that the primary endpoints, response rate, and then primary endpoint PFS. And what you can see on the right side is that these patients had a number of prior HER2 targeted therapies. But despite this, you see considerable activity in the CNS with TDXD. So across stable brain metastases, active brain metastases, untreated, previously treated, progressing, so that even patients who had been treated and progressing were still getting responses with TDXD. So here again, you can see that there's this early stratification if patients have brain metastases. And I think it's really important to know that we're really changing fundamentally how we approach brain metastases. But I strongly feel that local therapy still is so important. And I early get my surgeons, my neurosurgeons involved, my radiotherapist to come in and figure out how to best resect these tumor because it does remain the primary modality. And again, these patients live for many years, some of them 5 to 10 years. So if we can resect it in a way that produces the least amount of morbidity, I think this is critically important. So where are we heading? So as I said, one of the first things is looking at, do the patients have ER expression? So is there a role for an treatment with an ADC first line in HER2 positive metastatic disease? I showed you that data with second line therapy where the PFS was longer in second line than in first line. So it makes a lot of sense. Can we move these compounds up earlier in the treatment? So I think you're all quite familiar now with the Destiny Breast 09 study that was presented by Sarah Tillany. Looking back, this was patients with HER2 positive advanced breast cancer. Asymptomatic or inactive brain metastases were allowed. DFI was greater than 6 months from their last chemo or HER2 targeted therapy. 1 line of prior endocrine therapy for metastatic disease, but no other systemic therapy for metastatic disease. Patients were stratified versus de novo versus recurrent, stratified hormone positive or HER2 negative, and PIK3C mutations. As we know, these patients tend to do a lot worse. So patients were randomized to TDXD alone, TDXD plus pertuzumab, or THP. The primary endpoints were PFS by BICR, key secondary endpoint overall survival. This was the PFS data presented by Sarah Tillany at ASCO. You remember I was telling you about the PFS in first line. 40.7 months was the progression-free survival in this first-line setting. TDXD plus pertuzumab versus THP of 26.9. So ironically, that control arm is actually better than what we see with Cleopatra, better than what we see with historical controls. So what's impressive is despite a very profound control arm, we're still seeing an improvement in PFS in this first line setting. Hazard ratio of 0.56, log rank p-value of less than 0.00001. And you can see that those curves separate quite early. So the question is, do we need pertuzumab or is TDX sufficient? Because in this study, there was an arm with TDXD and plus pertuzumab, and so we eagerly await the results of that arm of this trial. Now, looking across all of the subgroups, you can see that there was consistent response and improvements in PFS across all of those relevant subgroups. This is really important as we're in clinical practice. We want to know which patients potentially should we be giving TDXD plus pertuzumab in this first line setting. Response rates, we see an improvement in response, 85 versus 78, but a much higher rate of complete responses. So doubling 15.1 versus 8.5 in complete responses. And I think what we really do see with antibody drug conjugates, which I think it really differentiates from traditional chemotherapy, is that ADCs really have a profound effect on duration of response. And so you see the median DOR was 39 versus 26.4 months. And I think this clearly probably is the reason we see this improvement in progression-free survival. Now, it's important to note there's only 16% maturity, so at this early stage, neither arm we can comment on overall survival. Looking at PFS2, not surprisingly, we see an improvement in patients receiving TDXD plus pertuzumab. You can see that PFS2 has not been reached in the TDXD plus pertuzumab and is 36.5 in the THP group. Looking at safety, really no new safety signals in this overall safety analysis, and similar median treatment duration for the taxanes and cycles. Now, looking at the toxicities, all of us use TDXD quite commonly in our practice. And so I don't think there are any new safety signals that were alerted in this. We see higher rates of nausea and diarrhea in the patients receiving TDXD. But I think we'd all agree that we've learned to manage those toxicities quite well. We see a little bit more in terms of anemia and leukopenia in the patients that are treated with THP. I want to also highlight another interesting study that was done in the ER positive, HER2 positive space, and this is the Patina study. So, what I think is very interesting is that years ago, those of us in clinical practice, if we had someone who had THP, then we put them on sort of maintenance antibody therapy. It took us a while to think, oh, we should actually add the endocrine therapy back in. But it took us a while. Our patients were doing quite well. And then we saw this robust data with endocrine and CDK inhibitor therapy. And so I really love this trial because it really says, does this actually translate into benefit for patients with ER positive, HER2 positive disease? Because when these patients present, many of them have aggressive disease. And could we potentially defer when they go on to another therapy? So this is a trial looking at patients who are initially put on 6 to 8 cycles of the equivalent of THP. Some of them actually got vinorelbine HP. And then after 6 or 8 cycles of therapy, they either went on to receive endocrine maintenance with their HER2 targeted therapy or continued with their HER2 targeted therapy plus endocrine, but in addition received the CDK inhibitor palbociclib. And the primary outcome was investigator initiated assessed PFS. So I think many of you have seen this data already. This is the primary endpoint. So continuing just the anti-HER2 plus endocrine was 29.1 months, and then the patients receiving palbociclib was 44.3 months. So it was significantly prolonged, and you see that very early separation of the curves that is sustained when patients are getting the additional palbociclib in that after that induction therapy with chemotherapy, and you can see it's consistent across these different subgroups. Again, this is looking at the overall response and CBR, again with palbociclib, but I think it's difficult to compare given the patients have already had their induction chemotherapy, and we await to see if there's an improvement in overall survival. Now, not surprisingly, you are going to see increase in toxicity when you add palbociclib. And obviously, this is important when you're treating your patients. You're going to see a lot more myelosuppression. You're going to see a little bit more fatigue as compared to the patients that are just getting HER2 blockade plus endocrine therapy. But not surprisingly, the patients getting endocrine therapy do have some myalgias and arthralgias potentially from their aromatase inhibitor. Life is just about to get even more complicated. So this is the HER2 CLIMB-05 study. This is looking at tucatinib or placebo in combination with trastuzumab and pertuzumab as maintenance therapy for HER2-positive metastatic disease. Now, it's gratifying to know that we're in this position that patients do well on their induction chemo plus HER2 targeted, but what do we do after? I just talked to you about giving endocrine and CDK. This is actually looking at the addition of tucatinib with pertuzumab and trastuzumab, and we await the results that is presented at an upcoming meeting. Now, what about side effects? So I think we're all quite familiar now with TDXD. One of the most notable side effects is ILD. And I think what's reassuring to know is that you look at the grade 4 or 5, this is extremely rare. You do have to understand, though, about who is at risk. We now know that patients have renal dysfunction. There are certain subgroups that are at higher risk, and we know that we have to follow the guidelines and monitor these patients appropriately. We also have to look, there's some really great websites to adhere to. What does grade 1 mean? Well, this is asymptomatic and is clinical or diagnostic observation only. Grade 2 or 3 or 4 are the patients that you're going to stop the drug, you're going to treat them, but you are not going to go back to TDXD. But having said that, there are a lot of grade 1 patients potentially who you can re-challenge. And I really alert you to Hope Rugo had presented this at ASCO, looking at treatment re-challenge after TXD-related ILD. And I think after COVID, many of us, including our radiologists, are they really have an eye out to look at any signs of changes on the lungs. And so I think it's really important that we discuss what we're seeing on the imaging with our colleagues. And what we can see is that 75% of patients with grade 1 ILD were re-challenged, and that ongoing clinical benefit after re-challenge. And I think it's really important to mention that in my practice, this is really important because those patients with HER2 positive disease that have CNS metastases, this is such an important treatment to be able to continue. And if we have a way to potentially re-challenge them, if they're grade 1, if they're asymptomatic, this data is very helpful in our clinical practice. The other thing that's come up, though, is radiation necrosis. And I think more and more we're seeing SRS and gamma knife. And what we are seeing is a slightly higher rate of radiation necrosis when we're giving antibody drug conjugates with even SRS. And so I urge you to discuss with your radiation oncologist. Hold it the week before, hold it the week after. But more importantly, you may need to do things like optical spectroscopy, which is done by MR, are different ways of looking at that imaging because it may not be disease progression, and the patients may, in fact, be asymptomatic from the radiation necrosis. What are the future directions? As I mentioned, there's a tsunami of antibody drug conjugates coming. A lot of it will depend on the schedule you're curious you want to give to your patient. It may also come to side effects. But I think we're really excited about some of the novel antibody drug conjugates that are coming out, as well as potentially some immune therapies and cellular vaccines. The other thing is we've got some really interesting data on how to de-escalate, and this is the STOP study. At 3 or 4 years, our patients are doing well on their HER2 targeted therapy. Is there an opportunity to stop? And many of the trials ongoing right now will give us some better guidance as to what to do in our clinical practice. We know that there's also mechanisms of resistance. Our colleagues, Leif Ellis and other colleagues, are help us identify who are the patients that have de novo resistance or have acquired resistance. What's the next therapy that's best after that? With this, I want to acknowledge my many colleagues who generously shared slides. Thank you.
Rebecca, thank you so much. This was truly a wonderful, comprehensive lecture on the entire spectrum of HER2 targeted treatment. I loved your wide perspective coming all the way from Cleopatra now to the ASCO data and putting that also a little bit into context with this year's ESMO meeting. I have like 1,000,000 questions. I'm sure the audience has like 2,000,000 questions, and we will have time to discuss those in 30 minutes after the next talk. Before we get into the discussion, we will listen to Professor Nick Turner, and he'll speak about hormone receptor positive, HER2 negative metastatic breast cancer, expanding and optimizing first line treatment options, a tumor biology which has seen as many evolutional steps as we just saw in the HER2 positive setting. I'm very much looking forward to Professor Turner's talk.
Well, thanks very much for the introduction, Wolfgang. So this is going to be a talk that very much focuses on the first line treatment of ER-positive, HER2-negative breast cancer. And of course, our standard of care in this setting is endocrine therapy with a CDK4/6 inhibitor for those people who are potentially AI sensitive, AI with a CDK4/6 inhibitor on the back of these studies that, of course, is well known to all of us. And then for those patients who relapse on an adjuvant AI or within 12 months of stopping, we have the indication of fulvestrant and a CDK4/6 inhibitor on the back of these 3 studies. So first of all, let's look at the data together about endocrine therapy and CDK4/6. Is this for everybody in the first line setting? First, let's look at the patients who are perhaps at the more aggressive end, and some of the studies that have asked the question about should we be treating these patients with chemotherapy instead of endocrine therapy CDK4/6. So the first study to look at this was the Young Pearl study in premenopausal women that randomized patients between exemestane palbociclib and capecitabine, Roughly only half of these people were first line, the remainder second line. But in this study, nonetheless, we saw a clear benefit for palbociclib and exemestane instead of being treated with capecitabine. We've then seen a subsequent number of trials, right choice, but I wanted to show you here the phase 4 PADMA study that we saw very recently. There was a first-line study that randomized people between physicians' choice of chemotherapy with maintenance ER endocrine therapy later, or endocrine therapy and palbociclib with time to treatment failure as the primary endpoint, and gave really very clear evidence for the superiority of giving palbociclib and endocrine therapy as opposed to chemotherapy. So really, endocrine therapy and CDK4/6 inhibitor is the standard. Currently, guidelines say that for life-threatening disease, it should start with chemotherapy and then follow on with maintenance endocrine therapy and CDK4/6 inhibitors. But I think we're right to ask the question, actually, should endocrine therapy and CDK4/6 perhaps even be a standard for these patients? And then at the other end of the scale, we have the question of should single agent endocrine therapy be an option for some people? And this was, of course, addressed by the SONIA trial that randomized people between first line AI, second line fulvestrant, and then when you gave the CDK4/6 inhibitor, did you give it in the first line with the AI, or did you give it in the second line with the fulvestrant? And this was certainly the academically perfect design to ask this question, but limited clinical relevance, as we've learned that really giving single agent fulvestrant for most people is inadequate therapy after people have progressed on an AI and CDK4/6 inhibitor, because single agent fulvestrant has a low efficacy in this patient population. And that's one of the factors that has limited us taking through the conclusions of SONIA into clinical practice. And what we saw in SONIA is only a non-significant improvement in PFS2 in those patients who had CDK4/6 inhibitor in the first line as opposed to the second line setting. But this study does remind us that for people who are older with lower risk cancers, where you'd only want to give them fulvestrant in the second line, really questions whether we need to give these people AI and CDK4/6 first, or whether it would be perfectly acceptable in that specific population to give them AI alone. So what about escalating therapy for patients in the first line setting? And so we're going to look at the 2 phase 3 studies that have looked at this, and we'll discuss some of the evidence behind it. So the first, of course, is a story about ESR1 mutations in advanced breast cancer. So these are, of course, the major acquired mutation of ER-positive breast cancer. The mutations cluster in the ligand binding domain, where they lock the estrogen receptor in an active state, and they result in ligand-independent ER signaling, so activation of the estrogen receptor without estrogen. So we know, looking at some data that now is a little old, but we know that these are only really acquired in AI therapy. They're not acquired through tamoxifen, and they're acquired when the tumor is sensitive to its endocrine therapy as a mechanism of acquired resistance. When the AI therapy is used, has a really big influence on when the cancer gets, whether the patient acquires an ESR1 mutation in their cancer. And this is our initial data and then some subsequent follow-up data. So if you give an aromatase inhibitor just in the adjuvant setting, the patient is relatively unlikely to acquire an ESR1 mutation, whereas if you use exactly the same therapy in the metastatic setting, there's a high rate of ESR1 mutations. And this is that heterogeneity we know exists in metastatic cancer that, if you like, allows the tumor to acquire these ESR1 mutations, and subsequent studies have confirmed this. About 10% of people who relapse on adjuvant AI have an ESR1 mutation, but over 40% will acquire them during first-line AI with a CDK4/6 inhibitor. And so a number of years ago, we asked the question, if you can acquire these mutations at progression, how long before progression can you identify them in circulating tumor DNA? And so we did this study that showed about 6 months prior to progression, you can start to detect them in circulating tumor DNA. And that, of course, subsequently led on to the PADA-1 study by François Clement-Bédard and colleagues, who looked at patients who were on first-line AI and palbociclib, doing regular circulating tumor DNA blood tests to detect the ESR1 mutations, and then randomizing people to continuing the same AI plus palbociclib or switching over to fulvestrant, and showing that first proof of principle that switching treatment prior to progression, guided by ESR1 mutations, could improve PFS. Now, fulvestrant is not a very good inhibitor of the ESR1 mutations. And of course, we now have the oral ER degraders, the oral SERDs, that are substantially better at targeting ESR1 mutations. And this brings us on to the SERENA-6 study that we showed at ASCO earlier this year, which was taking the same concept of PADA-1 into the phase 3 study. And so in this study, we screened over 3,000 patients who are on their first line an AI and CDK4/6 inhibitor for at least 6 months, with circulating tumor DNA testing every 2 to 3 months. And ultimately, this allowed us to find patients with ESR1 mutations that had not progressed and randomized 315 patients. And so these were 315 patients, all on AI and CDK4/6 inhibitors. All 3 of the routinely approved CDK4/6 inhibitors were represented, and they had an ESR1 mutation but without progression. And 315 patients were then randomized to continuing AI and CDK4/6 inhibitor, double-blind with a placebo for camizestrant, or switching to camizestrant, continuing the same CDK4/6 inhibitor, and the placebo for the AI. And the primary endpoint was PFS. And when we looked at PFS, switching treatment to the camizestrant substantially deferred progression-free survival with a hazard ratio of 0.44. And importantly, at 24 months, 30% of people still hadn't progressed when they switched to camizestrant. The benefit was essentially the same across all subgroups that were looked at. But what was quite a striking finding in this study was the substantial improvement in quality of life by switching to camizestrant compared to continuing AI, with a substantial prolongation on time to deterioration in quality of life. Camizestrant, very well tolerated as an oral SERD. Broadly speaking, the AE profile was similar between the 2 groups, other than this small increase in photopsia, brief flashes of light in the peripheral vision that were found in the camizestrant group. So when to use a SERD? So we know SERDs are approved, obviously, in the second-line setting, elacestrant broadly, imlunestrant currently only approved by the FDA. So when do we going to use oral SERDs to target ESR1? Are we going to use them guided in the first-line setting by finding ESR1 mutations? This defers progression. It maintains quality of life by deferring symptomatic consequences of progression. Extra monitoring may increase reassurance. And importantly, all patients with ESR1 mutations will have the opportunity to have a SERD, whereas many patients, when they progress, will potentially have other treatments such as chemotherapy or PI3 kinase AKT pathway, and possibly miss out on the opportunity to have a SERD. whereas potentially delaying and treating at progression has alternative pros for that. There was a very low rate of crossover in Serena 6, so we'll not really know the benefit in terms of overall survival of starting treatment at molecular progression guided by ESR1. There'll be some anxiety whilst waiting a week or two for the results, and obviously there's some cost to ESR1 mutation monitoring. What about escalating therapy for those patients who are on fulvestrant and CDK4/6 inhibitor? And this is the story for PIK3CA mutant cancers of PI3 kinase inhibition, where we know on the left, if you target ER, PI3 kinase signaling, and CDK4/6 inhibitors all together in the bottom right, you get more efficacy than just targeting two of these key aspects of biology. And then on the right, we're looking at combining a PI3 kinase inhibitor and a CDK4/6 inhibitor. You see really durable responses preclinically when you combine both drugs together. And so this was taken forward into the INAVO 120 study that took patients in the first-line setting who had relapsed on their endocrine therapy or within 12 months of stopping. They had PIK3CA mutations in their cancer, predominantly identified by ctDNA testing, and they were randomized between a standard of care of fulvestrant and palbociclib or the addition of inavolisib to give triplet treatment, with inavolisib being a alpha-selective PI3 kinase inhibitor that specifically degrades the mutant PIK3CA. And importantly, inavolisib can be combined with the other agents at the maximal single-agent dose. So you're doing just what you want here, combining, targeting all of these three key pathways in the biologies of these cancer with the maximum tolerated doses. And we saw a substantial improvement in progression-free survival by the addition of inavolisib with a hazard ratio of 0.42. And then earlier this year, we also showed that you could substantially improve overall survival by adding inavolisib in that first-line triplet with a hazard ratio of 0.67, improving the median OS from 27 to 34 months. In other secondary endpoints, there was a really substantial improvement in objective response rates from 28% up to 63%, and also an improvement in the duration of response by adding in inavolisib. Interestingly, when we looked at post-progression therapies and just looking for just at this top line here, that actually those patients who had the triplet were less likely to have chemotherapy in the second line than those patients who had the standard of care doublet. So presumably that increased tumor shrinkage you get not only gives benefit in that first line setting, but it helps people avoid chemotherapy in the second line setting as well, where they have the potential to receive endocrine-based options instead. But of course, inavolisib is a PI3 kinase inhibitor that comes with toxicity consequences for the patient of stomatitis, hyperglycemia, diarrhea, and rash, and some dry eye as well. And so is best substantial benefit for the patient, but with some toxicity as well. So what do we think about targeting PIK3CA in this first-line triplet as opposed to potentially leaving targeting PIK3CA to a subsequent line? Well, if we look at the benefits for that inavolisib triplet in the first line, we've seen a substantial improvement in PFS, response rate, and overall survival in that first-line triplet, and this has been the only study to show an improvement in OS with a PI3 kinase AKT or mTOR inhibitor. 10% of patients in the control arm were dead at 6 months, unfortunately, so they were not rescuable by therapy after progression. And in many countries, alpelisib or capivasertib, for that matter, is not funded in patients who've previously progressed on fulvestrant, so they just won't be able to get a sequential doublet. But conversely, the arguments for a sequential doublet is there is a substantial increase in the adverse effects of adding in a narvalisib to that first-line fulvestrant CDK4/6 inhibitor. There were low rates of crossover, and so we can't really assess the impact of the low rates of crossover on OS, and the toxicity of a narvalisib triplet may not be appropriate for all patients, especially those with low volumes of disease. And so therefore, just to conclude, we've just reviewed the really substantial progress we're making in the management of first-line ER-positive breast cancer by escalation of therapy. For high-risk patients with PIK3CA mutations, the triplet therapy we've just been looking for, and then for patients on AI and CDK4/6, monitoring for molecular progression with ESR1 mutation testing that enables us to prolong first-line therapy and avoid the adverse symptomatic consequences of progression, and then gives all the patients the potential to benefit from targeting ESR1 mutations for a SERD. And then we just reviewed the possibility still of giving first-line AI alone for older patients. And I'll finish there. Thank you.
Thank you so much, Nick, for this also wonderful comprehensive overview of first-line treatment options with all the aspects, escalation and de-escalation. I'm very happy that we have 40 minutes room for discussion. Our discussion will have three main topics. We will start with what you heard about from Rebecca Dent about HER2-positive metastatic breast cancer. And the questions, what will be standard of care in this situation? Then we'll jump to ESR1 mutated disease, of course, focusing on, among other aspects, on Serena-6, we just heard from Professor Turner. And then we'll, when we still have some time, get to the third topic. How do we optimize treatment approaches for hormone refractory metastatic breast cancer? And we'll leave first line a little bit in this setting. We'll focus both on first line and on further line. So let's start with topic one. Are you guys ready? If that is the case, let's look at the first polling question. Based on current trial data, what first-line strategy are you likely to adopt with T-DXd in future for newly diagnosed HER2-positive metastatic breast cancer? Well, Rebecca, you summarized so eloquently the Destiny Breast 09 study. Let me just make you the advocate for the majority here in the audience. What would be your arguments that we should give T-DXd for all our HER2-positive newly diagnosed patients? I know all patients never is right, but let's say usually for patients with newly diagnosed HER2-positive breast cancer.
So first, I have to acknowledge that, this would not be possible in some parts of the world. We won't have access. I think it's really important to mention that. I think the every 3-week dosing for many of our patients is quite convenient. And I think one of the challenges in metastatic disease is our patients with HER2-positive disease develop CNS metastases. And that's really quite crippling and very difficult as a clinician. So I would say, for me, the biggest advocate to doing it first line would be to even prevent patients who haven't even developed HER2, related CNS metastases. So I think if that's the reason why, then I think that would be the strongest argument to support that first line setting. And then I think the key thing is going to be in the future is figuring out what could be our maintenance strategy. I've had patients for years on T-DXd. Is there a point at which we could de-escalate to something else? And I think some of the future trials could address that.
Well, thank you very much.
It's a good problem to have.
Thank you. So the best drug, or the most efficacious drug in the beginning is, I guess, your main point. Peter, I mentioned it already, for all patients never, of course, is correct. So What would be your caveats on first-line TDXD for the vast majority or for almost all patients?
I mean, it's always a difficult decision if you don't give the most effective therapy in the first line setting. But ultimately, we don't know yet what is the best strategy. If you look at the delta in PFS in the first line studies compared to second and third line studies, that delta is relatively similar. So, in other words, if you just do simple maths, which doesn't work between trials, you may actually get to a very similar overall time we can control HER2 positive breast cancer. The second point is to look at the toxicity profiles. If you look at the previous or the current still first line standard of what we call TPH, trastuzumab pertuzumab combination, the majority of patients stay for a very long time just on monoclonal antibodies with very limited toxicity. And I think that's very difficult to beat with any drug in terms of quality of life. If you then consider that the Destiny trial did not allow the use of, well, it wasn't routinely given the use of CDK4/6 inhibitors, especially in the ER-positive breast cancer patients. We don't know whether the delta in PFS would be that high if patients had received a CDK4/6 inhibitor in the control arm. Ultimately, I think the jury's out. We come from an era where it was very easy for HER2-positive breast cancer. Everyone got the same treatment. And I think the future will be that we probably have to think, and there are some patients who are very well treated with the current standard of TPH, and there are some patients where I would definitely give TDXD as a first-line treatment. One point what I would like to see is this group of patients who achieve a complete response, which is obviously higher with TDXD compared to patients with TPH. Is that complete response possibly translating into long-term disease control? We know that there's a small percentage of patients with HER2-positive breast cancer who have long-term disease control. And it's probably those patients who respond best. And this is also something we see more commonly in the de novo metastatic patients. So I think where we need to wait for a little bit more data to work out who are the patients where we want to give everything in a first-line setting, who are the patients where we want to face it. Our instinct at the moment would say we give TDX2 to higher risk patients, but it may not be the right strategy if the lower risk patients with de novo metastatic disease are those with CR and a long-term benefit. And then the point Rebecca sort of sneaked into the discussion, which I think is absolutely critical. Do we need to look at TDXD treatment from beginning to progression, or do we look at it as an induction therapy? And there are interesting trials ongoing. We could discuss how that may pan out. But I think an induction, maintenance, reinduction strategy could be really interesting from a patient point of view.
Yeah, we'll come to the duration and maintenance aspect in just a minute. I'm not sure whether you would have voted for high-risk patients only or whether you would have voted for individual patient factors. What would have been your vote?
So I think with the data we have, I would probably select the patient more on the higher risk factors for first-line setting. But I think we need to wait for data whether the lower risk patients who achieve possibly a complete response with de novo metastatic disease may be patients who have an overproportional benefit.
And how do you find high risk? So what would be your typical first-line TDXD patient, after all?
I think it comes down to the interval between primary disease and recurrent disease. It comes down to the metastatic size. So if you have a patient who relapses 3 years after initial therapy with a bone met, that is not a high-risk patient. On the other hand, if you have a patient who relapses within a year with substantial visceral involvement, that is a patient where we're anxious about getting a response.
I'm going to pick on you a little bit because you had some time to relax as the other two were
I feel
speaking.
bullies.
Yeah. So our fellow audience asking TDXD versus Cleopatra was really comparing continuous chemo or ADC versus just maintenance after induction chemotherapy. Can you comment on this comparison? And can we extrapolate and try to escalate to TP plus CDKI? So these are basically two questions. So is this an unfair comparison? Question one. And question two, how about triple positive?
So fair or unfair is difficult. I mean, TDXD is a targeted chemotherapy that combines obviously the HER2 effects and combines chemotherapy. So as such, you could argue it's an unfair comparison, not continue with chemotherapy, but no treating clinician would continue with chemotherapy with trastuzumab pertuzumab until progression if the disease is well stabilized. So I think it just brings it back to what we said earlier. We may need to think about maintenance strategies and a switch and then possible sort of reintroduction, which I would find, a reinduction, which I would find clinically really interesting. So coming with a TDXD induction strategy, maintaining with trastuzumab, pertuzumab, and depending on whether ER positive or negative, at possibly additional drugs, for example, at endocrine therapy and CDK4/6 inhibitors, at progression, possible cfDNA progression, reinduced with TDXD, because I would expect that drug to still have activity in that setting. That would be something I would like to do clinically, and I would like to see in terms of trials.
Well, thank you. This reflects also to another question from the audience. Is there a way in this moment to do less cycles of TDXD and then continue with maintenance therapy? Same thought. What is the voice of the Royal Marsden?
Yeah, I think this is the key challenge with how we interpret Destiny 09. I'm also a strong believer in giving the best therapy in the first line setting, because I think this is where we've got the most potential to impact the cancer. We know cancer starts to get much more heterogeneous from that second line setting on. We'll never be able to really assess the impact of overall survival of giving it in the first line setting, as there was very low rates of crossover. So we really need to focus on the benefit we see in that PFS analysis. And I don't think I would like to give TDXD indefinitely, as was done in the study. And the key challenge is, if we give TDXD only for a period of time and then follow it by maintenance, will you get the same benefit you saw in DB9 or not? And I think that's going to be a really big challenge for thinking about the benefit we see in DB09 and how do we bring it into clinical practice. There are phase 2 studies that are addressing this, and the results of those are going to be really important for me in getting a sense to which the benefit of DB9 is just the fact that you're continuing the chemotherapy indefinitely, or is it that superior efficacy you get in the induction period that enables much durable PFS? And so I'm personally a little bit on the fence right now, especially for lower risk, lower volume cancer patients, until we sort of start to see some of that data that might help us think about how we might use this in clinical practice.
Peter.
So just in terms of is it continued or long chemotherapy or short chemotherapy? I think it's not just the chemotherapy effect, because if you look at the second or third line data where the control arm had often chemotherapy until progression, you still see that dramatic difference in PFS rates, or when you compare it to TDM1 or other antibody drug conjugate, which is then targeted chemotherapy. So I do think it is the efficacy of the drug, but everything else Nick says I would agree with, and I think we know now this is a highly effective and transformative drug in this setting. What we haven't quite worked out is where to use it for all patients, and we may not have to use it for all patients first line, and we have to learn who are the patients who benefit most. But there's no doubt that every patient should get TDXD at some point in their treatment.
So I hear little doubt that TDXD is moving towards the first line standard, but I hear a lot of thoughts about that, how that has to be defined exactly.
Well, we haven't spoken about the elephant in the room, is what do you do post TDXD, and what is approved and what is available and what is reimbursed. And we do in our minds, we say, okay, you give TDXD first line, and then you get a similar benefit we had with Cleopatra, with TPH afterwards. But the reality is that isn't going to be the case. We will see less of a benefit if give TPH second or third line. That's just the nature of breast biology. So we will have to see how effective those treatments are in real life outside in clinical trials and what we are allowed to give in our respective countries.
Absolutely. This would have been one of my two remaining questions for this section of the discussion before and after first line TDXD standards. So, yeah, what is the best sequence after TDXD first line, Rebecca?
So I think this is where the art of medicine comes in. I mean, I think if we were smarter, and the hope is that AI potentially could help evaluate, what the tumor looks like after exposure, whether it's TDXD or something else. I didn't have a time to get into it in my talk, but we've looked at HER2 expression after TDXD, and there's considerably lower HER2 expression. And so I think many people feel that it's good to sequence it with, a chemotherapy plus HER2 directed therapy after that, because it might not be as strongly HER2 driven. And I think that's where the current studies, I think, will guide us. And again, it could be AI enabled to understand under the selective pressure of these different treatments. Every patient actually could be different and guide us accordingly. And I think we have this massive armamentarium of treatments. And I think it's important to look at, well, what are the side effects of the patient? Of the treatments they've just had, and then shift to match the biology, but also the schedule. Do they want something oral? Do they want something subcutaneous? Because we do have a number of options. What amazes me, to be honest, though, truthfully, is that all of these agents still seem to get benefit in my clinic. We've had a lot of patients who've had tucatinib followed by TDXD or TDXD followed by tucatinib with substantial burden of disease in the CNS, and it still seems to work. So I think what's really reassuring is that these patients continue to do well, and we shouldn't shy away from, you won't have trial data to support everything you do. And that's what makes it hard if you're in an environment where you're bounded by regulatory approvals. And so we have to work together to work on those to help provide that evidence so that, physicians can help their patients in the way that they need.
Let me take the complexity even one step beyond. You mentioned Destiny Breast 05 study. We'll see the results here at ESMO 2025. So, what to do with patients who already had TDXD in the early breast cancer setting in future?
Peter and I both worked on Keynote 522. What we see is that a lot of triple negative patients now don't relapse, don't have metastatic disease. And so, in fact, we don't have as many patients for trials. So I suspect with giving, some of these compounds in either the neoadjuvant, as in DB11 or DB05, we will have fewer patients with metastatic relapse. So that's a good thing, and we shouldn't shy away from that. But I think we're going to have to actually collect the tissue and understand what the tumor looks like when it relapses in that context. Is it still HER2 driven, or is it another clone that we should be focusing on? And I think we'll do those trials and we'll understand it. But as I said, I think there'll be fewer patients, so we'll see when that comes.
And I think what Rebecca's was actually exactly on my mind as you were saying it. With post 522 setting, we cure a lot of patients, but those tumors that survive that treatment and then relapse are unfortunately incredibly difficult to treat and quite aggressive. So we will have to see whether something similar will happen post and post ADCs opposed to TDXD in an early HER2 positive breast cancer setting. In a pragmatic way, once we are allowed to do this, if there's a certain interval between your adjuvant possible use and then recurrence of patients, I think it is reasonable to reintroduce that, as we do with chemotherapy as well. And it is ultimately a targeted chemotherapy. So whether that interval is 6 months or 12 months, we will have to discuss this and what we're allowed to do. But I think those would be the lines I would be thinking along.
Thank you very much for that perspective in the future. I would love to continue this discussion on HER2 positive metastatic breast cancer. I'm afraid we have to jump to the next topic. And it was Nick Turner who challenged a first line standard in metastatic breast cancer at this year's ASCO meeting by presenting the Serena-6 study in the presidential session. And based on this and the data he presented at this symposium, let's put out this question. What is your current opinion on the use of ESR1 mutation monitoring before first clinical progression? So doing the very same which was done in the Serena-6 study, and Nick Turner so eloquently summarized the data. Should it be A, implemented as standard of care, B, valuable in some patients, but not as standard of care, promising data, but I'm waiting to see more. Or D, data are currently unconvincing. I'm not going to do that. Nick, this is a challenge for you. Well, we saw the data again today. We saw them at ASCO, and now you saw them here in Berlin. Why wait?
Well, so I think if we look at the Serena 6 and we think about how we'd implement it, because you've got that on your slide, Wolfgang. So we'd be implementing it because we have our people in obviously 3 monthly to do their blood count. And so they'd be having ESL1 mutation testing taken up the same blood test. And then if we detect an ESL1 mutation, we'd just be switching their hormone therapy from their AI to camizestrant. If we sort of compare with the previous discussion we had with TDXD, the advantage of camizestrant, of course, is really it's extremely well tolerated. So really, there's little downside for the patient of switching from AI to camizestrant on the basis of having a 3 monthly blood test. But the upside is really quite substantial. We substantially defer PFS. And what we've really seen in the quality of life, what we know in the clinic, which is that first progression really matters for people. What we've seen in the quality of life is there's pain, and we see the substantial decrease in pain in the quality of life and time to pain by switching to camizestrant. And of course, that first progression is psychologically really difficult for people. So in many ways, doing that ESR1 monitoring, being able to switch to a therapy that's very well tolerated and substantially improves PFS and quality of life is in many ways what we try and look for in new treatment approaches. The other reason why I think it actually really could become a standard is in that second line setting, we have quite a few options for patients. And certainly not everybody who has an ESR1 mutation is going to get, say, elacestrant in that second line setting. Some people will need chemo. Other people, for example, will have capivasertib. And we all know the challenges of the data is that roughly 40% of patients will get no benefit at all from targeting ESR1 mutations with elacestrant. They'll just progress straight through it. We see that, of course, in the cliff. And so that second line setting has actually a challenge for implementing targeting ESR1 mutations in the clinic, but you don't get that challenge if you're giving it before progression guided by ESR1, and all patients who are developing the ESR1 mutation will get the potential to benefit from oral SERDs, and at progression they can go off and have the multiple other options we've got available for targeting our patients. So actually, I think if we sort of do the pluses of Serena 6, we see really substantial benefits on why this could become a future standard of care for our patients.
Thanks, Nick. Peter, if I understood Nick correctly, he thinks that it is practice changing. The data of Serena 6 are practice changing. It's going to be standard of care. You're far away, but you looked a little bit skeptical. Did I interpret that correctly?
Well, I think there's no doubt it's a beautiful study. Yeah, Padawan and Serena 6 are two beautiful academic studies that provide fantastic proof of principle of what we can do with biomarker-guided therapy. But there are a lot of questions that are not answered at this point in time. And I think so if all of this pans out, if all the buts we have are taken away, this may very well turn into a standard of care. But one of the things I have in mind is we have slightly unbalanced control and experimental arm in terms of access to treatments. And the crossover to oral SERDs is very limited in the control arm. also the crossover then to a second-line strategy. We know it's not widely used, but we know CDK4/6 after CDK4/6 has some PFS benefit. We know that switching to the oral SERD in patients with ESR1 mutant at progression has, especially in those patients with a long response initially, about a 6 months delta in PFS. If I remember the data rightly, the average time or median time patients were on their first line treatment before they were switched in Serena 6 was more than 20 months. So this is a sensitive group of patients, and this is a group of patients where the trial data show you get a benefit from single agent oral SERD afterwards. Now, so the elephant in the room is we have too few patients in the control arm who had oral SERDs, and we had too few patients who could have combination therapy. We'll see data coming up here at ESMO that looked at SERD and then targeted therapy combination with everolimus. And I think we will see future data as well with target combination second line. One of the challenges a lot of us have clinically, if you have a patient who's progressing on a first-line CDK4/6 combination, we feel a little bit uncomfortable in many situations giving single-agent endocrine therapy. And I think one of the beauties of the Serena 6 study is you could keep your CDK4/6 inhibitor in there, which we know or can show a benefit. So with emerging data that allow us to use, hopefully, a combination second-line strategy, ESR1 mutant targeted, but also giving a second drug in there, it will be interesting to see whether actually over time this really prolongs the time patients can stay on endocrine therapy, which for me is the most important endpoint. It's not necessarily, survival is always the key endpoint, but ultimately until we get to hormone refractory disease is the most critical point in change in treatment strategy for patients. And I don't think we have those data yet.
But I hear that you believe in biomarker-navigated treatment in metastatic breast cancer. Before I ask Rebecca what her typical patient for ESR mutation monitoring would be, let me just ask Nick. I heard some concerns also in questions here about that patients were not allowed for crossover in the Serena 6 study. Why was that the case?
Well, it's the same in so many of our studies about lack of crossover. Of course, in DB9, there was very low crossover. And so I think it is always a challenge as we look at the line we give treatments. Are we going to give TDXD in the second line or the first line? Are we going to give oral SERDs in the second line or the first line guided by ESR1 mutations? I think we know that the registration studies are not going to be able to address whether the line of therapy impacts OS. And Sonia shows it's extremely hard to address this question in clinical trials. So for me, it's all about the benefit you see in the trial. And here we've got something that substantially improves quality of life with really no increase in side effects for patients, while substantially improving PFS, which for me at least is what we're trying to do for our patients.
Sounds like a very compelling and clever idea to navigate that by a biomarker and keep on the CDK treatment. So Rebecca, what would be your typical patients in which you in future will do ESR1 monitoring?
So I think the first thing to acknowledge is that because we're in general treating with adjuvant aromatase inhibitors for a longer period of time and we're giving CDK inhibitors, what we're going to see in the future is actually going to be actually even very different from Serena 6. And what I mean by that is every subsequent trial I've seen in the first line setting actually has a higher rate of ESR1 mutations. So this actually may become even more relevant for us because we know this emerges under the selective pressure of exposure to aromatase inhibitors. So I have a feeling this is going to hit our clinic in a much more profound way in the next 2 to 5 years. I think the other thing is that we have to acknowledge is that if this testing were less expensive and we had a little bit more consistency. Let's be honest, there's many ways to get an ESR1 mutation readout. And I think that's very confusing for all of us. We're trying to keep on top of all the technologies, but, this used one technology, but what's the best technology and does it matter? And that needs to be ironed out very quickly.
Mm.
If it was cheaper and more readily accessible, I think we'd all do it, quite honestly. We want to know this information. I sort of liken it to BRCA testing. 20 years ago, it was so expensive when you had this really rigid criteria. Now we're talking about mainstreaming because it has therapeutic indications. So I think as the technology progresses, I think we're going to find that we're much more, and it's just a blood draw. It's so much easier. So I think we're going to see that change. And I think the final thing is, I think, we have a broad range of oral SERDs, and I think as we start to use them, and I think that sort of impressive curve on the quality of life, how much is actually just coming off the aromatase inhibitor versus how much is the effectiveness of the SERD preventing, treatment-related toxicity? I'm not sure. So I think the bottom line is I think we will be using it more often, and I respect that why there wasn't crossover that was done, but I think it's an exciting future so that the only I think is, could we have such a range of patients in our clinic. For those patients that I have a patient I saw just before I came, 15 years, and she's never seen an IV treatment. Where I've seen other patients where she had early emergence of an ESR1 mutation, and she just doesn't respond to traditional therapy. And so the hope is that as the technologies are more accessible and less expensive, I think we will be incorporating it earlier. So this is congratulations to Nick and others who are brave enough to do this, because I think this is a fundamentally new way we will be approaching, and I do hope we will be doing less radiological investigations so that we can rely on this also to monitor disease where it becomes more challenging, especially with bone only disease, where our current imaging modalities do not give us the full picture.
Well, thank you very much also for bringing that methodology aspect in here. Um, I'm afraid we're a little bit running out of time. Let's go right to the third topic and let's do our final round of discussion. So we need your help both from the faculty and from the audience. And we'll jump to the polling question, which is case-based and kind of tricky. AI plus CDKI for 5 months, patient with PIK3CA mutation, and now has a progressive disease. What would be your choice? Would it be capecitabine, single agent therapy? Would it be fulvestrant plus alpelisib if it's available? Would it be fulvestrant plus capivasertib? Would it be the triplet, which was mentioned as first line, but of course he is second line, mentioned in the Novel 120 study, fulvestrant, inavolisib, palbo, or would it be TVXT in this setting? Aha. So C, D, and E, capivasertib or the first line triplet moved into second line or TDXT. So, Rebecca, because you have to head over early to the opening session, but before you are allowed to do so, give us a little bit of insight.
So I think the most important to recognize is that we always have options and choices. And I think that's the great part of what we do in treatment of breast cancer. It's not cookbook. It really is individualized where you work and what the patient wants. And so as you can see, what was interesting is that we had quite an even split there between BCDE. I must confess I'm not using fulvestrant alpelisib so often anymore because I do find it's difficult to deliver in terms of toxicities. I think this current case, those patients that progress after 6 months, I think we have to be very cautious when they have endocrine and CDK inhibitor. If they progress, this is a bad player, and you have to be very cautious. And so it says she has limited disease, but I'd also want to know what she'd had adjuvantly. Has she already exposure to chemo and years of endocrine therapy? Because obviously that does make me sort of a bit worried that she's going to go through an early EMT switch, and so I need to be a bit more aggressive. But I think the other approach is, she falls a little bit outside the INOVO, but I think the data that Nick showed is really quite impressive. I'd be keen to give that. I think fulvestrant Capiva is a good option, but I'd really keep TDXD up my sleeve very closely because, as we recently showed, this is a compound that works in patients who have both ESR1 mutants and PIK3CA mutations. So I'd be very quick to sort of be ready with that because I would be concerned that this patient's disease trajectory is going to be changing very quickly.
Thank you so much. And I'm looking at Peter now. What in this situation, what is the role of TDXD? Or make it a little bit broader. What is the role of TDXD in hormone refractory disease?
Yeah, so I think we're discussing two questions at the same time. And one is, how do we define hormone refractory disease? And what do we do in hormone refractory disease? And this case was actually really interesting in that way, because some of us may feel this is already hormone refractory disease with a disappointingly short PFS on first-line CDK4/6 inhibitors. And others said, well, this is possibly, it's hormone-resistant disease, but maybe not yet hormone refractory, and therefore we give a second-line endocrine treatment option with capivasertib or inavolisib triplet. And I think that's one of the areas where we will need to learn. Is there a group of patients where in the future we just stop endocrine treatment earlier? Because we all said we give 2-3 lines of endocrine therapy, but there may be a small group of patients with very unfavorable biology in the tumor where the tumor turns hormone refractory relatively early on. And this picture could be one of those where we can come to a conclusion this is early hormone refractory disease. If we have established it's hormone refractory disease, obviously hormone therapy is out of the discussion, and then it's chemotherapy versus ADC, which is a similar discussion to HER2-positive breast cancer, where we had, do we give the best treatment first or not? And again, it's an individual treatment decision based on pre-treatment, based on risk factors. The higher the risk is, the more urgently we need to achieve a response, the more likely I would choose an ADC.
Well, thank you very much. Nick, you'll have the closing statement, so to speak, on the aspect which was mentioned by Peter. If the decision is made in favor of ADC or chemo, what are your thoughts between the two of them?
Well, I was just going to actually make the point that there's actually not a strong link for benefit from capivasertib or alpelisib combination on how long the patient was on their AI and CDK4/6, because we know that PI3 AKT signaling is one of the mechanisms of resistance. So actually, although there's a strong link with benefit of single agent endocrine therapy and duration of CDK4/6 in that second line setting, it's not there. So for that kind of patient, I would be very comfortable to give them fulvestrant and capivasertib. The question of, say, capecitabine versus TDXD for this kind of patient is a really important patient-led decision for which we have to discuss the pros and cons. Lots of people will want to avoid the hair loss and have capecitabine first, whereas much more symptomatic patients at risk of visceral crisis, I would push much more towards ADC for the increased efficacy.
Well, thank you so much. I take away that in this situation, you think that capivasertib-based treatment is still a good option, and I hear your voice that you say it doesn't correlate with the 5 months or the duration. Well, thank you so much, the two of you. It's been a lot of fun, a lot of insights I take away with me. Hopefully, also the audience here takes away. Thank you so much for showing up at this very beginning of the ESMO 2025 convention. Thank you very much for visiting this symposium. Thank you so much for coming.